Good morning, everyone. We have made it to the last day of our conference. Today we have two presentations like for the days before, and I'll start by introducing myself. I'm the moderator for today and also the program coordinator for the HDRN Canada Pragmatic Trials Training Program. And my role is to help coordinate and facilitate the administrative portion of the program. And I would like to begin today with a land acknowledgement. We acknowledge that the Pragmatic Trials Training Programs Coordinating Team's office is located in London, Ontario, are on the traditional territories of the Anishinaabe, Haudenosaunee, Unapiwak, and Atawandran. This land continues to be home to diverse Indigenous peoples, First Nations, Métis, and Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. We also recognize that our work is carried out on the traditional territories of First Nation, Inuit, and Métis people from coast to coast. We're thankful that we're able to work and collaborate on these lands. Just a brief overview of the agenda today. We will begin the first session at 11:10, and our first presenter will be Dr. Rahul Chanchlani, and he will be presenting on pediatric blood pressure screening through pharmacist-led initiatives in Canada. And we also have three panelists today who will be asking him questions, and then we'll move on to audience questions. So if you're in the audience and you would like to ask questions, you can throw them in the chat or raise your hand in the Zoom meeting just to get your questions answered. If we don't happen to get to your question on time, then we will make sure to forward it to the presenter post-conference. And then we also have a second presentation in the afternoon by Dr. Nahid Jibraj, and we will resume the second session post-lunch. So that will be around 45 minutes, and then we will end the conference today at 2. Just some housekeeping. If you have any questions, please feel free to add them to the Zoom chat. Don't use the lobby chat as much because we might not be able to just double check that. So it's safer to just put all your questions in the Zoom chat. And you can also, in the networking space on FeedLoop, message people privately. And if you have any feedback that you would like to have passed along to the presenter, then feel free to email us at the Pragmatic Trials Training email address featured above, and we will make sure to pass it on to the presenter. And I will pass the floor to Rahul, and you can begin when you're ready.
Thank you, Victoria, for the opportunity, and I also want to thank everyone for coming for the fourth day of this conference. I am a pediatric nephrologist at McMaster Children's Hospital, and I'm also a scientist at ICES and PHRI. And I think this is the only pediatric presentation that we have today, so let's jump to it. So the title is Enhancing Blood Pressure Screening in Youth through Pharmacist-Led Initiatives in Canada, in short, Screen BP. Again, happy to change the acronym if people don't like it. So what's the research question? So because this has never been done before, we thought that we should we should go with a feasibility trial first rather than jumping to the main trial, just so that we get some idea about is it even feasible or not. So the feasibility question is, what is the feasibility of implementing pharmacist-led blood pressure screening among youth aged 13 to 18 years in Canada? And the reason for choosing 13 to 18 years is that both national, Canadian and US and European guidelines now classify anyone who's 13 years and older as an adult in terms of the blood pressure cutoff. So it's easy to implement that compared to younger children, in which we have to look at blood pressure centiles cutoff, which is a bit tedious to see in pharmacy or in a healthcare provider setting. For a main trial, which is the future objective, we want to understand whether pharmacist-led blood pressure screenings improve annual screening rates and early identification of elevated BP in youth aged 13 to 18 years compared to usual care. So, a brief background on pediatric hypertension. So, until few years earlier, we used to think that hypertension is an adult problem. It does not exist in children. But now we have solid data coming for the last 10, 15 years that hypertension in children as well as in youth is quite common. And this is a very interesting study published in JAMA Pediatrics, 5 years back, in which they systematically evaluated the global prevalence of hypertension from the year 2000 to year 2015. On the y-axis, you see the prevalence of hypertension, and the x-axis shows the age from 7 to 19. And the blue line suggests the prevalence in the year 2000, which was approximately 1.1 to 1.2%. And you can see here that the green line has shown that the prevalence of hypertension has gone up to almost 6% in the year 2015, which is a pretty significant jump in just 10 to 15 years. And that shows that childhood hypertension is a major public health challenge worldwide. So what is driving all this hypertension in our children? So earlier, again, our thought was that it's the secondary hypertension, such as kidney problems, heart problems, hormonal issues that are driving all this hypertension in our children. But now we have changed our understanding, and we now know that it is the lifestyle of these children which is driving all this high blood pressure, primarily the rising rates of obesity, increasing salt intake in our children, lack of physical activity. These are the three main risk factors which is driving all the hypertension in our pediatric population. So this is a pretty significant change in our understanding also in the last 10, 15 years. But despite the known increase in the risk of hypertension, there are certain knowledge gaps in our field. And the most important one is a lack of blood pressure screening. So you'll be surprised to note that 60 to 90% of our children, when they go to their primary care providers, they do not have their blood pressure screening. And the common reasons are because of conflicting guidelines around blood pressure screening, lack of awareness on blood pressure issues, both in primary care providers as well as family members. Then we do not have access to validated blood pressure devices and cuffs for all our pediatric age ranges. What is more interesting is that if a child has high blood pressure detected in the first visit, around 50 to 90% of these children do not have a follow-up visit to check whether the first blood pressure was actually high or not. And the guidelines say that within a month or within 3 months, they should be followed again to check their blood pressure. And again, the main reasons are primary care providers are busy. They do not get the health alerts, or sorry, the electronic alerts of high blood pressure. There is always some observer bias when it comes to blood pressure. Clinics are always busy, and again, there is lack of understanding or lack of awareness around blood pressure in children and its consequences, both in primary care providers as well as the family members. Because of these issues, approximately 70 to 90% of children are not diagnosed with hypertension in time, and approximately 90% of children do not receive the proper care that they need, both in terms of non-pharmacological management as well as medications in time. So I compare the care that we are giving to our children in terms of hypertension to the care in 90s, which is the care that the adults used to get in 90s when there was lack of awareness around adult hypertension also, and see how the adults have changed their care. And now every time an adult, then they go to their primary care provider, they get their blood pressure checked, right? But that's not the case in our pediatric population, and that's what we are trying to change. So because of all these issues, how are Canadian children being affected? So this is a very interesting study published by my colleague, Dr. Alison Dart from Manitoba, in which she and her colleagues included the SIPSON database. SIPSON is a Canadian primary care sentinel surveillance network database, which has data on more than 350,000 children across 8 provinces from 2011 to 2017. And what they found was that only 33% of their children got their blood pressure checked across this time period. And what was more interesting was that when a child was found to have a high blood pressure, only half of these children got their blood pressure repeated within 6 months of that first visit. So you can see clearly that there is a very suboptimal care that we are providing our children when it comes to hypertension screening. But you might be wondering, what's the big deal here? Why do we even bother checking blood pressure in our pediatric population? Well, as I said earlier, we used to think that there is no long-term outcomes associated with pediatric hypertension, but in the last 5 to 10 years, there have been so much novel and exciting data in this field, and we have been able to show, and some other researchers around the world have been able to show that pediatric hypertension is associated with long-term outcomes, which I've tried to categorize here in 5 major categories. The first one is blood pressure tracking into adulthood, meaning there is solid data now that shows that even from 7 years of age, there is a strong tendency for blood pressure to track as much into late adulthood. So if a child is hypertensive, they are very likely to be hypertensive as they age into adulthood. There is also strong data coming from Canada as well as across the world around cardiovascular morbidity and mortality, which I'll share in the next slide. There is also data from our cohort as well as from Israel showing that pediatric hypertension can lead to future chronic kidney disease as well as end-stage kidney disease. There is data around cognitive outcomes, and there is strong data that children who have hypertension utilize healthcare resources much more compared to normotensive children. So a quick update on cardiovascular outcomes of pediatric hypertension, which is the most important ones. And this was a study published in New England Journal of Medicine just 2 years back from the I3C consortium. This is an international childhood cardiovascular cohort study, which is a longitudinal cohort, running from 1990s, and they have data on more than 38,000 individuals, right from 3 years of age to their mid-adulthood, and they also have blood pressure data. And in this study, their primary outcome was cardiovascular disease. So on the y-axis, you see the hazard ratio of cardiovascular outcomes, and the x-axis shows the blood pressure categories from low normal to hypertension. You can see a very nice linear association, between hypertension and future cardiovascular outcomes. So we also published a similar data using our Ontario Health Administrative Databases at ICES, which was published in JAMA Pediatrics a few months back, in which we did a retrospective cohort study in which we included children who were diagnosed with hypertension using validated algorithms from 1991 to 2019. And we also created a propensity matched cohort of 120,000 children without hypertension, which were matched on key variables which are known to cause high blood pressure. And this cohort was followed over time until 2020. And our median time to follow was around 13 years. And what we showed that was that the primary outcome of MACE, which is major adverse cardiovascular events, was much higher, almost 2 times higher in the hypertension cohort compared to normotensive individuals. And the risk of all secondary outcomes was also higher, including stroke, congestive heart failure, as well as cardiovascular procedures. So this and other data have shown that prevalence of hypertension has gone up in children, and there is long-term outcome associated with pediatric hypertension. So we need to start screening our children. But there is one strategy which will not work when it comes to improving screening in our pediatric population. It has to be a multifaceted intervention. We need to understand the barriers and perceptions in both primary care providers as well as patients and families. And some of this work is already going on with our research team. We also need to create some clinical decision support tools to help primary care providers help start checking blood pressure and start recognizing high blood pressure. And we also need some innovative strategies, such as working with key stakeholders, such as policymakers, social media influencers, hypertension organizations, and also utilizing pharmacists and school nurses, which have been shown to be very effective in certain parts of the world, but have not much used in our pediatric population in Canada yet. So just to summarize, I think I was able to convince you that the risk of hypertension has gone up in children, and there is now data to show that these children, if they are not treated, it is associated with long-term outcomes as they age into young adulthood. But screening is still suboptimal. Less than 25% of children are being screened for high blood pressure. And it's not a good idea to just blame the primary care providers because they are already overwhelmed with so much other issues in our pediatric population. They have heavy workloads and they have competing priorities, and that's why we need to have some out of the box thinking. And pharmacists actually have been able to show a very successful community based screening of high blood pressure, as well as management of blood pressure in our adult population. There have been more than 100 trials to show that if you utilize pharmacists, you can improve the care of these hypertensive adults, and you can show a reduction in blood pressure in the adult population. But there is no data as of now to show whether we can utilize pharmacists to improve blood pressure screening in our youth population. So with this background, the primary objective of a trial, which is again a feasibility trial, is to assess whether it is feasible to have pharmacists check the blood pressure in youth between 3 to 18 years of age across Canada. And our recruitment rate is approximately 50 youth per pharmacy over 1 year. And our secondary outcome is to see if we can utilize pharmacists to send referral to healthcare providers such as family physicians, pediatricians, or nurse practitioners if the blood pressure is found to be high. And as I mentioned before, youth or teenagers who are 13 years and older now have the same cutoff as an adult. So it's not like they have to remember too many blood pressure cutoffs. It's just one cutoff for children who are 13 years and older. And one other outcome is that if we can utilize pharmacies or pharmacists to provide some lifestyle counseling for high blood pressure. So for this study, we are collaborating very closely with Hypertension Canada and Canadian Pharmacy Associations. And this pragmatic trial will be this feasibility trial will be a pragmatic cluster randomized trial within community pharmacies as a unit of randomization. We'll include youth between 3 to 18 years of age with no known history of hypertension who will visit the participating pharmacies. In terms of consent, we are still working on it. Do we need consent for this kind of study or not? But 16 years and older participants do not have to have a parental consent, and we'll talk about that and when we come to discussion. So the setting here is community pharmacies, which are already involved in the May Hypertension or May Measurement Month campaign, and I'll talk about this campaign in the next few slides. And we are hoping to utilize 10 pharmacies in Ontario, British Columbia, and Alberta. Again, these are part of the May Hypertension Month campaign that has been successfully running in Canada for the last few years. And we'll be able to stratify pharmacy to make sure that we have nice geographical representation. So the intervention for this feasibility trial actually is to make sure that we are able to capture enough youth, and they should be able to come to pharmacies. And we are trying to understand how can we have these teenagers to come to pharmacy for their blood pressure checking, because it's not it has never been done before. So I think that is the intervention for this feasibility trial. So we had a few ideas. The number one was running some social media campaigns, and I have a team of learners who are working on creating an infographic or creating like a TikTok video that we can post on various social media platforms, which will also be announced at Hypertension Canada website, so that they can have a look at it. It is known that if adult is hypertensive, their children are also likely to be hypertensive. So we are trying to capture those adults who are hypertensive and they are having their prescription being refilled. Can we ask some of these pharmacies to send a letter or an email to those adults and say, hey, we are running this campaign for blood pressure screening. If you have a child between 13 to 18 years of age, can you bring them to the pharmacies for their blood pressure checking? One other way to reach these teenagers when they come to the pharmacies for vaccination, over-the-counter medication for weight loss, acne, headache relief, any kind of prescription medications, then we can always have the pharmacies to encourage them to check their blood pressure while they are there. Obviously, there will be some flyers and posters distributed within the pharmacies, and that's where we are working with the Pharmacy Association across Canada. And one other idea was to connect with the family doctors who have adults with hypertension, and they can also do a similar email or a letter to these patients and say, if you have a patient, if you have a child between 13 to 18 years of age, can you bring them to pharmacies for a quick blood pressure check? So that is the intervention for the feasibility trial. In terms of blood pressure measurement, so I will talk about in a minute, but as I said before, May Hypertension Month has been going on by Hypertension Canada for a few years now, and they have published their data. So as a part of this May Hypertension Month, pharmacies across Canada are being trained for blood pressure checking. They are given a validated blood pressure machine and cuffs by Hypertension Canada, and there have been consultation with the pharmacy student as well as pharmacist, and we are part of those consultations, and we'll be making sure that they are checking blood pressure using the best practice guidelines by Hypertension Canada and using validated devices. So the primary outcome for this feasibility study is to have a recruitment rate of at least 50 youth per pharmacy over a period of 1 year. And again, we can talk about it if this is practical or not. And also the screening rate. So once they are checking their blood pressure, can we have at least 90% of the youth who got their blood pressure screened successfully at the pharmacies? In terms of secondary outcome, as I mentioned before, we wanted to see if they can be for those who are found to be hypertensive, can they get some blood pressure referrals to be sent to their primary care providers, and can they receive some lifestyle counseling? And again, by the way, all this has been done already as a part of May measurement campaign by Hypertension Canada. There is a REDCap database that has been established in combination with Hypertension Canada and Canadian Pharmacy Association. So the only thing we are doing additional is to add the 13 to 18 years of age in this month's campaign. So in terms of data collection, we want to keep it very short and simple. So we will ask them some basic demographic information, their age, gender, ethnicity, their immigration status, if they have access to primary care providers, so that referral can be sent, height and body weight, just to see the ratio of overweight and obese patients, and if they have any kind of relevant medical history that can lead to high blood pressure, and obviously family history of hypertension or any kind of cardiometabolic events. So what we have done so far, as I mentioned before, we are working very closely with Hypertension Canada and Canadian Pharmacy Association for this May Measurement Month. This has been a campaign by International Society of Hypertension that has been going on in more than 90 countries for many years now. And the idea is to use some pop-up sites in communities to start checking blood pressure for those who are unaware whether they are hypertensive or not. And in Canada, this has been done using pharmacies, and they have successfully published their report. This was just published last month in the Canadian Pharmacy Journal. This is their experience from 52 pharmacies in the May Measurement Month campaign in 2023, in which they were able to recruit 52 pharmacies, and they were able to get blood pressure checked in 736 participants, and found that 21 of them were having high blood pressure. And as I mentioned before, they already have an established REDCap database for data collection, and the data is transferred to Hypertension Canada. So where we are right now, I think, as I said, we are having some active discussions for this 2025 May Measurement Month. Hypertension Canada has approved to include the youth population, so from 13 to 18 years of age, and we'll see if we are able to capture enough children during this this May month in 2025. We still have to do some formal sample size calculations for the main trial, and obviously, procure some funding. And challenges that we can think about is actually bringing teenagers to pharmacies and to get their blood pressure checked. We have to navigate some ethical issues around blood pressure checking if their parent is not with them, and what happens to those individuals if they are found to have high blood pressure but they do not have a primary care providers to be sent referral. We are also working actively with the physicians, so the primary care providers in Ontario at least, to try to understand their barriers and perceptions around blood pressure screening. And that work is also important to make sure that we are not just relying on pharmacies and pharmacists, but we also work with primary care providers to start improving blood pressure screening. And we are also getting some perspective from patients and their families. So this work is led by Dr. Geeta Wahi and Dr. Sujane Kandasamy here at McMaster, and they are interviewing patients in our clinic to try to understand their barriers and perceptions around blood pressure, around adherence of lifestyle and changes and the medications. So with that, I'll end, and I want to thank you for listening. And I also want to thank my funders for some of this work that we have done so far. I want to thank the team at the CIHR Pragmatic Trial Training Program, my collaborators at Hypertension Canada, some of the learners that we are working with, and I'm happy to take questions.
Thank you, Rahul. That was a great presentation. So we'll just move on to the panelist questions. And I'm happy to introduce the panelists today. We have Shamini Selvakumar, we have Kevin Yao, and we have Janice Dion. So we'll go in order of the images that are on the screen currently, and each panelist will ask one question, and then we'll go back around once each person has had a turn. And so I will just turn the floor over to the panelists, starting with Shamini.
Hi, everyone. My name is Shamini Selvakumar. I'm a general pediatrician and assistant clinical professor at McMaster University. Thank you, Rahul, for a really great presentation. It sounds really interesting. I think you alluded to this in your challenges. So my first question is actually just around access for and your population. So we know that teens in general are less likely to access medical care, and those of certain ethnicities or SES background are even less likely to access medical care. So just given that those are also risk factors for having hypertension, how are you going to ensure equitable access to all adolescents to participate?
Great question, Shamini. And that's where the social media influencers will come. So I think we are working with our learners. I don't know if they're here. I invited them to join, but the idea is to create infographic and a TikTok video that can be then translated into different languages so that everyone on Facebook, Twitter, X, TikTok, whatever channel they use, they can just see about this campaign, hear about this campaign, and then hopefully come to the pharmacies. And as I mentioned before, for the feasibility trial and for the main trial, we have to have pharmacies also in the low, geographically distributed locations so that we are capturing all kind of, ethnic groups as well as the low socioeconomic status groups. So it's not only in the affluent Toronto area, but it's like distributed pharmacies, which hopefully will capture all kind of ethnic groups as well as the socioeconomic groups.
Great presentation, Rahul. It's been interesting to see sort of, you develop the trial question, and I think you've probably had some discussions or thoughts about the actual design of the trial. And I think, if I'm not wrong, initially the trial design was to be a cluster randomized controlled trial, and initially the outcome focused on the pharmacist implementing the intervention. And while in the feasibility trial, I think the focus is more on ability to recruit children into the trial. Is the plan for the feasibility trial also to be cluster randomized, and are you still thinking of that for the main trial?
Still thinking on that, Kevin. And again, as I said, I was a bit late in planning all of these things, but happy to take suggestions from the panelists and from other audience. But the idea is to randomize the pharmacies rather than doing individual level randomization, because the ultimate goal is doing a step wedge cluster randomized trial in which we have a group of, say, I don't know, 200 pharmacies. And because right now none of the pharmacies is doing screening in the youth population, so we implement this study And the idea is that all those pharmacies would then eventually be able to do the screening for the youth population. That's the entire hope. So that's why randomizing pharmacies is better rather than an individual level. For the feasibility trial, I would still stick to the pharmacy level randomization rather than individual level, randomization.
Janice Dion, I'm a pediatric nephrologist at BC Children's, and one of my areas of interest is hypertension, and I've been part of the Hypertension Canada pediatric recommendations as well as the American Academy of Pediatric guidelines. Rahul, I think this is a great idea, especially now that we have threshold blood pressures for adolescents. It's finally time, and with the very poor screening rates of hypertension in adolescents. But my big area of, interest and bugaboo, I guess, is to make sure that it's done, those blood pressures are done right. So can you tell me more about, what has been done so far? Like, what devices do they use? What's the method? How many readings do they do? Are they going to have the right blood pressure cuffs? Often I go into the pharmacy and I just see those devices where people can sit in and put their arms. So if that's what they're using, is there a minimum arm circumference we should have for the trial? Because I know this is feasibility, but if we're not getting good readings, I'm not sure we should consider it feasible.
Yeah.
So can you tell me more details about the measurement methods?
Yes. Thank you, Janice. So as I mentioned before, the May measurement month has been campaign that has been going on for many years, and Hypertension Canada is very invested in this campaign, in which for the last, I think, 5 years or 4 years maybe, there are multiple pharmacies across Canada which they kind of do training, online training with Hypertension Canada on the best practices on how to check blood pressure. So, you have to sit for 5 minutes and check a proper, and they are doing 3 readings. The machines are provided by Hypertension Canada. These are Hypertension Canada validated machines with different size of cuffs, automated devices, not auscultatory devices. And they are asked to take 3 blood pressure measurements, and all 3 blood pressure measurements are recorded into a REDCap database, and that information is sent to Hypertension Canada. So it's already a well-oiled machine that Hypertension Canada has invested across the Canadian Pharmacy Associations, and they have been working with them closely. Every year there is a training session in around this time, and this time I'm also involved in these kind of sessions on how the training will be done, what kind of devices will be provided, but these are all validated devices. I just don't know if they have a youth validated device. You know what I mean? Like I think they are adult validated devices, but we have to see if there is a device that they are specifically providing for the youth population. That I don't know.
I think you'll be okay as long as, if we're talking adolescents, as long as there's small to large adult size cuffs, which most machines have, I think you're going to be okay with that.
Yeah. So as I said, this training is done by Hypertension Canada for a few years now. They already have established pharmacy associations, and the only thing they are new this year is that we are including youth population. So that's the pragmatic part of this trial, that no more extra resources are being spent. We are just having more youth coming to pharmacies this year. Hopefully they show up.
Do any of the other panelists have any additional questions for Ro?
I have another one. I just was wondering about, particularly, especially teens that don't have a primary care provider, and let's say they have a hypertensive, like their blood pressure is really high. Is there kind of a measure to ensure that there is follow-up, or will the pharmacist have access to, like, yourself or like to someone to be able to get guidance? Like, I'm a bit worried about, if there's a teen walking around with like a $6, 150s, and there's no one following up on it.
Yeah, we had this discussion, Shamini, and it's a tough one. So one option was that we provide them with a letter saying that you have hypertensive blood pressure range and go to a walk-in clinic to like get it assessed or get a referral, because that's where ethics come in, right? Like what is our ethic responsibility when we see a hypertensive child? Um, that's what we could think about so far, but if there's any other suggestions, happy to take it.
I just thought, from a safety point of view, maybe you should have an upper blood pressure limit where you would send them to emergency. Like, I think you need some safety background within this. So choose a value that a teenager, and we know if it's chronic hypertension, sometimes it can be quite high. But what value would you be uncomfortable just letting them hand a letter? And at what value would you want them to at least go to emergency as a backup? And then everybody in between, we can figure out where they get referred or something.
Yeah, so I think we'll follow the same guidelines. So stage 2 hypertension for now, anyone who's 13 years is 140/90, more than 140/90. We say, okay, if your blood pressure is more than 140/90, maybe say, let's say 150, systolic, you got to go to emerge. If it's anywhere less than that and more than 130, they should be going to to either primary care provider or to a walk-in clinic.
I had another question, sort of on a similar lines in terms of you mentioned there's sort of challenges if they don't have a primary care provider. And I think part of what you were hoping to see is like how many people follow up with a primary care provider. What's sort of the thoughts or the ways that you're planning to have the referral done by the pharmacist? Is it just to see their family doctor, or is there someone else that they could be sent to?
Yeah, so as I said, there is already established REDCap database through Hypertension Canada and Canadian Pharmacy Association, and they have been doing for adults as well. If they found an adult to be hypertensive, they will send a referral to their family doctor saying that, hey, this is a patient who has high blood pressure. Can you please follow up? Now, when it comes to youth, I think similar process will be followed. If the primary care provider is not comfortable in managing or follow up, then they will have to send a referral to a pediatric nephrologist or cardiologist, whoever is available in the vicinity, or maybe a pediatrician as well, for that matter. But that's the usual. I think we just want to see, as a part of this trial, was a referral sent to the primary care provider, and if we can link it then to health admin databases or some other databases, then we can see the follow-up of these individuals over time. The idea is that if we can link somehow this national, database to individual provincial healthcare databases, then we can follow their trajectory over time and see what happened to them. Did they even visit a specialist? Did they even get their investigations done, blood pressure checked, urine checked, all those kind of things done as a part of the workup? But for this trial, I think the outcome is a referral sent to their primary care provider.
So I have a question or thoughts around the main research question. So do adolescents actually visit pharmacies enough to make use of the screening? So do you know so if you're saying come for prescriptions and vaccinations, do you know what percent of all people going to the pharmacy for those items is actually adolescents, or if it's not a high number, could you catch them when they come, as you say, maybe they're just with their family, but then it makes it hard to get that denominator for your feasibility study. So how are you going to manage catching them, but know what your denominator is? If you're trying to just like grab them from whatever route you can, then it becomes hard to get that denominator for trying to decide the feasibility.
That's a tough one, Janice. I don't know actually, and that's where this May 2025 campaign will be really important to see, can we actually have teenagers coming to pharmacies? But again, the denominator will be hard to find. And that's why we are trying to do multiple things to have them come to pharmacy. But again, even if they're coming to pharmacy not getting their blood pressure checked, how do how do we get the denominator right? The denominator will be a problem. I agree.
I'm sure some of those participating pharmacies probably could tell you, like from an age point of view, what percentage of, say, prescriptions or vaccines are of a
Yeah.
certain age. So you may be able to get an idea of likelihood of catching the number that you're hoping to just based on that. I'm sure that they would have data on the number that people or prescriptions within a month and the number that fall within a certain age, I would hope.
That, and then, as I said, we will also have the pharmacies who are part of this campaign to send a letter to their adult patients and say, hey, if you have a child between 13 to 18, can you bring them to? So we also have that number, how many letters were actually sent. And the same thing will be done by primary care providers who are linked to the pharmacies nearby to send a letter. So there is an indirect way of capturing the denominator, but there is no way, least I can't think of any direct way of capturing that number.
Unless your denominator becomes the number in the store that were asked to participate and declined or accepted, I suppose.
Yeah. And that's where I think we need to flesh out this a little bit more with the methodologist.
Did you have any other questions, panel?
I just had another question. You mentioned that I think pharmacists, there have been a lot, as you mentioned, there have been a lot of trials related to that. And then, as Ms. mentioned, the kids or adolescents who go to a pharmacy, they might be a little bit different from sort of like the general population, because most kids who are healthy may not be going to a pharmacy except for maybe vaccinations.
Yeah.
And so that's where the additional recruitment strategies are coming into play. Did you think about or ponder about like other settings for intervening beyond pharmacies? For example, you mentioned school nurse. I don't know if there's not necessarily a school nurse in every school, for example, but was that a consideration, for example?
Yeah. Thank you, Kevin. I have been talking with Ontario public health folks to see if there is any interest, because there are school nurses who screen children for like vision and hearing. These are generally younger children, and blood pressure checking in them might be a bit tricky. But some schools, and again, I don't know the data, some schools do vaccinate teenagers for HPV vaccines. And Shamini might know, I think she's a pediatrician, she might know the number, but I think we have to, again, talk to all these stakeholders. As I said, I am also in very close discussion with primary care providers, at least in Ontario. There is a network called as Poplar Network, which links all the 7 major primary health centers in Ontario. And I am presenting this talk to them also next week, and see if there is any interest in collaborating in this kind of blood pressure screening, either at their offices or somehow collaborating with pharmacies to have the primary care providers talk to the pharmacies that they usually send their patients or in their vicinity, and see if those pharmacies can check blood pressure and then refer those which are, because primary care providers on my initial talks, they said we are so much overburdened, I cannot expect every single child walking into their primary care provider and getting their blood pressure checked. They say we will not be able to do that. It's not something that will work as of this point in time. But they said that if somehow we can get a referral from either school nurses or some other care provider, then we are bound to do the blood pressure checking. That's the message I got on my initial conversations, at least in Ontario. But again, I don't know about other provinces. So we are trying to do all these strategies to make sure that we are not just, putting all our eggs in one basket, with just the pharmacies doing it. It is a multifaceted approach.
If I may, I have 2 questions, but they both revolve around management or intervention. So you are hoping that the pharmacists are going to provide information and or counseling about a whole host of things, so diet and exercise and things. So I'm at the process right now of creating a clinical pathway in BC for helping the pediatricians manage hypertension. And each of those categories is going to take a lot of time to do it well. So how do you, like, are they currently doing these lifestyle advice? Do they have time to do it, or is it going to become the same issue as in the adult world? Because you really do need quite a bit of time to do it well. So that's my first question.
Yes, good question, Janice. So, what I gathered from Hypertension Canada and their previous campaigns is that they would be just distributing a brochure of like this much exercise you need to do. This is how you read a salt label. This is how much screen time you should be doing. We need to tailor it for the youth population because it's different when you talk to a 50-year-old versus a 15-year-old. So I think we need to tailor all of this, and that's why the feasibility comes in. Like, what practical feasible information we can actually provide, but happy to get your resources if you are okay to share. And again, I think there will be a lot of education session that we have to do with primary care, with the pharmacies, if we want to go to the intervention route. If it's just a screening, then it's easy. But if we want them to get, and I think that I will get that feeling when I first talk to them. I still haven't met with them. That meeting is scheduled for later this month. So I will gauge that, and like feeling how much comfortable you are in talking to a teenager and providing all these lifestyle counseling sessions, and how much time does it take? Are you even? And I think that's where the qualitative component will be also a good part of the study, that we are also trying to see, can we understand how much logistically it is possible for pharmacies to do all of these things in their busy practice, right? So all of these things is also part of our some of the qualitative work that we would like to do as a part of the study.
Yeah, and my second question is the next step further, which you may not be able to answer, but I know the scope of practice keeps getting bigger for pharmacists in different provinces because of the lack of physicians. So do you actually know, do pharmacists prescribe antihypertensives to newly like as they diagnose hypertension, can they prescribe it? And would you be comfortable with that in adolescents? And or can they order ABPMs to confirm whether it's true hypertension, things like that?
I don't think in Ontario this is happening. I don't know about other provinces, but in Ontario, I don't think adolescents are being prescribed medication, at least hypertensive medication as of now. Shamini, you practice in pediatric world. I don't think so, right? Yeah. I don't think this is happening, Janice. So, but again, when we talk, I think the first step is let's get screening done, and then gauge their involvement and say, hey, are you interested in also going to the next level of providing prescriptions or some lifestyle counseling sessions and those kind of things? Again, I don't know how will the billing work. Like, would they be interested in getting billed for it? I don't know that, right? So money will be a talking point also because they're investing time in each child and each adult. So I don't know if they're interested in a lengthy session versus just a simple blood pressure screening also.
Yeah, I mean, I love the idea of them starting on the counseling. It does take a lot to go through all of those different topics. I would be worried about having them
Yes.
do treatments. I would love it if they could refer for ABPMs. I don't know if that's feasible, but those are just my 2 cents.
Thank you.
Yeah, I had a similar thought, is that you're screening them for hypertension, and technically you should be confirming sort of that they truly have hypertension at a subsequent visit. And so
Yeah.
I guess what happens to those who don't follow up with a primary care physician to confirm the diagnosis? So if they were able to get ABPMs, that would be ideal. I think in some of the adult trials for hypertension, like there was a barbershop
Yes.
randomized controlled trial where in adults, I think the pharmacist was able to prescribe medication for adults, maybe in collaboration with a physician. I don't know that there would be that comfort for doing that for adolescents.
Valid points, Kevin. And I think all this will come to fruition when we first talk to these pharmacies and see how much comfortable they are in dealing with adolescents. Again, it has never been done before, right? And in Canada or elsewhere. So we first need to gauge their interest and their comfort zone in this area.
Did anyone on the panel have any other comments or questions? No? Perfect. So we can move on to the audience questions. I see someone already has their hand up. Go ahead, Sierra.
Hi, can you hear us?
Yes.
Yes, sorry, the camera's not working. This is Amit.
Hi, Amit.
At
Yes.
the coordinating center. Thank you so much, Raul, and the panelists. You know, I was a bit fuzzy on your design. I put this in the chat, like I'm not clear. Like there's a few options here. One is you could have like small cities and then have public awareness campaigns around measuring blood pressure, and then people go to their local pharmacies. And then if you have administrative data, you could track, again, how many people had diagnostic codes for hypertension, teenagers, how many had ultimately blood pressure medications, perhaps in some provinces. That'd be one design. Another design would be, okay, we will take, the pharmacists already have records of people who are teenage age, and or you're saying their parents who have teenagers who go through that pharmacy. And then you could individually randomly allocate patients potentially to usual care or this kind of like invitation to have your blood pressure checked and reviewed. And again, if you're using administrative data, you wouldn't be able to track like measurements at all, but you'd be able to track if, again, if they get a recorded diagnostic code, you could track like subsequent physician visits. You could track if like ambulatory blood pressure was, if that was a billed service, that could be also like tracked. And you know, of course, you could track medications. So I just, again, when your presentation, I was kind of quite fuzzy on what is exact the design. Like, is it the population? Is it, and then the denominator, is it the population, entire population, and you're looking at these rates? Is it people going to that pharmacy and rates? And then would there be, again, would it be simpler just to do an individual patient trial where you offer people in that pharmacy who already get their medications dispensed at that pharmacy the opportunity to participate in hypertension awareness or not? And then that's where your awareness campaign is targeted around people who are interested in that or something. I'll stop there, but those are just some thoughts that came to mind when I was listening to your nice presentation.
Good point, Amit. Yes, and I thank you for making me think out of the box during an initial session. So, few things. I thought about doing your latter suggestions in which only having adults who are hypertensive asking the pharmacies to bring their children. The problem is the selection bias, right? That was my main concern. We will have a good denominator, but are we targeting, I don't know, will we create a selection bias in that area of just having individuals who already are at a higher risk because probably of their lifestyle, their parent being hypertensive, and living in certain socio, demographic neighborhood. So for now, I was thinking just to do a cluster trial in which we do education sessions to pharmacies, and pharmacists and pharmacy students, which is already happening through Hypertension Canada, through the May Measurement Month campaign, and there is already infrastructure ready. And in this May of 2025, we'll come to know if this is successful or not, if we are able to engage enough teenagers in this initiative. I think this is quite fluid right now. I'm sorry, I'm not able to answer your question, but I think this May month will give us some idea about is it even possible or not to do this kind of intervention.
We have a couple of questions in the chat as well. I just wanted to see if anyone wanted to make a comment who commented in the chat and through the video function. If anyone wants to raise their hand.
Can I read Yasmin?
Yeah, I can read her comment. So Yasmin commented, as there's no is there's currently no screening or referral process in pharmacies. Randomizing based on pharmacies and comparing outcomes between these groups may not be ideal. Instead, I suggest randomizing practices to refer all their adolescent patients for blood pressure checks at designated local pharmacies, and then assessing the rate of primary and secondary hypertension between two groups and practices.
Yeah, good question, Yasmin. I think that's what Amit was also alluding. I don't know whether pharmacies would be able to differentiate between primary and secondary hypertension. They still have to do the referral. They cannot prescribe investigations as of now. So I think yeah. So I think the big question that both you and Amit are asking is, should like to have a proper denominator, should we have only the patients who are registered to a pharmacies having their children come to the pharmacy and getting their blood pressure checked? That's one. Or the other approach is just doing a campaign and try to have as many teenagers come to the pharmacies as possible. I think those are the two approaches that I can think of right now, but I just don't know about selection biases.
We have one more comment that just
Have
popped
you
up.
spoken to-
Gordon, he's asking if you have spoken to many teenagers about the feasibility of this trial.
Yes, we are going to Gordon. Good question. So as I said, we are still in process of creating some TikTok videos and infographics, and the idea is then to have like a focus group with these teenagers, a few in our community, and see if they are interested in something like this and get their feedback on these infographics and these TikTok videos to see if they have enough interest in these initiatives. But that's a good point. I will make sure it happens.
We have two more Q&A related questions. So one of them was, did you consider involving schools in the recruitment strategy for this pragmatic trial on screening hypertension in youth?
As I said, I have been talking to Public Health Ontario, and I got an initial pushback, to be honest, to have schools doing this. I've not approached individual schools because I cannot approach individual schools as of now, but I have to go through school boards. And I have been doing other studies in community in children blood pressure. In my initial, when I approached them a couple of years back, I got rejected from 2 or 3 school boards. And the reason was probably it was part of pandemic also playing a role, that they didn't want anybody coming from outside and getting blood pressure screened. But it's a good point. I think we can rethink about approaching schools also and seeing their interest. I was not able to get a link because Public Health Ontario was not very interested in reaching out to school themselves. They wanted me to do that. So I think I'm happy to do that also. Yeah.
And we have a longer question from Rani. So she is asking with something with relation to overtesting and overdiagnosis. There's a concern relating to causing anxiety and harm rather than a benefit with this aspect.
Yeah.
And they're also asking if you will have messaging for youth and families to have a high blood pressure to explain if it is a one-time reading, it may not indicate high blood pressure and further BPs are needed, so it won't cause too much alarm. And the second part of that question is, does HDRN Canada already have this type of messaging as part of their current program?
Hypertension Canada has part of it as, so that's why we are not labeling them as hypertensive. We are labeling them as having high blood pressure. But I will make that point clear. Thank you for that suggestion in our infographic and in our videos, that you're not hypertensive. You're just having high blood pressure. We need 3 different visits to confirm hypertension and probably ABPM as well. But we will make sure that happens. Thank you. That's a very good point.
And then we have a comment from Gordon relating to the social media aspect of the trial. If you can campaign to teenagers through their schools. And he also commented that interested and motivated kids can do a lot with supporting this trial as well.
Thank you. Excellent point.
Definitely. And did anyone else in the audience have any questions? Feel free to raise your hand or throw them in the chat. If there are no more questions, then, oh, Janice, go ahead.
Yes, yeah.
So I was just going to say, in terms of, the one-time elevated blood pressures, it's still an opportunity to talk about lifestyle issues, which most teenagers don't hear about. And I think the studies have shown that even the one-time elevated generally are slightly higher cardiovascular risk patients often than the ones that don't, even on a single reading. So I think that's still an opportunity to talk about lifestyle things, which is never a bad thing. And I forgot my other comment. Oh yeah, we're working on a qualitative study asking perspectives of youth with hypertension all about their journey with it. So if we get some results before you're working on your infographics, and so that you can tailor it to what the teens want to know or things like that, then I'll let you know.
Thank you, Janice. Appreciate it.
Anyone else from either the panel or the audience? Any other comments, questions? Nope. Perfect. So I would like to thank all of our panelists today. You gave very great feedback and asked very good questions. I'm sure Raul appreciates your additions.
So much.
And we can break for lunch now, and we will be back in the afternoon with Dr. Nahid Jibraj's presentation as well. And thank you, Raul, for presenting. Very interesting trial. We're looking forward to hearing more about it.
Thank you, everyone, for your feedback and listening. And if you have any other suggestions, please feel free to pass on. It's really, really important. This is the first time we are doing this, so it's any feedback is helpful here. Thank you. Okay.
Thank you.
Bye, everyone.
See you at lunch, after lunch.